of shock. So classification of shock. So please don't forget the two important shocks discussed in surgery, only you have to write. But first of all, you should know the basic categorization, that is hypovolemic shock, distributive shock, and cardiogenic shock. So these are the main three headings for writing the shock. In hypovolemic shock, we have two important reasons. One is due to hemorrhage, that is hemorrhagic shock. This is a very important shock with related to surgeons. Other causes of hypovolemic shock, you know very well, diarrhea, vomiting, all those causes also causes shock. So that's more of a medicine case. Distributive shock includes septic shock, neurogenic shock, anaphylactic shock. In all these shocks, the blood is redistributed in some other compartments. That is the reason for distributive shock. Okay, distributive shock. Cardiogenic shock is a shock due to myocardial infarction. So MI. So MI causing a shock is cardiogenic shock. Congestive cardiac failure. Okay, some causes related to the heart is known as cardiogenic shock. So this is a basic category. In this category, as surgeons, we will be dealing only two types of shocks, hemorrhagic shock and septic shock. Since it's a surgery essay question, if you write in detail about hemorrhagic shock and septic shock, it is more than enough. Okay. So first of all, to understand the shock, the pathophysiology behind the shock. So just you are going, I'm discussing right like an essay question. I will be telling the MCQ parts also. This is not for PG aspirants. It's mainly for final year students appearing for exam. Okay, it is mainly for final year students appearing for the exam. I'm discussing this topic. So for the pathophysiology, please understand I'm drawing an image which is not essential for you to draw, but you can write it in a tabular color form. I'll show you the table also. It is coming up next. So this is a patient. Okay, this is the patient. I'm going to discuss what all happens in the shock. This is the cardiac beat. So as heart beats, the blood goes through the arteries to the peripheries. This is the first important point. So as the heart beat, that is known as cardiac output. So we have to measure the cardiac output. So cardiac output is normally 5 liters per minute. This is a normal in adults. So as the heart is beating, 5 liters of blood is going to the peripheries. What is the function of this arteries? Arteries transfer the blood to the peripheries. So this is therefore is exhibiting a resistance known as peripheral arterial resistance. See, if you understand shock, it is not a big tough topic at all, because even when I'm doing a final year, I always used to be very much stressed that the shock should not come as an essay question. This is always a very common problem with many of the final year students. But please understand, if you know the basic concepts of shock, definitely you like this question to come for the exam. You can write excellently for even 6-7 pages essay question on this. So peripheral arterial resistance. So peripheral arterial resistance is the pressure exhibited by the arteries as the blood is going to the peripheries. So in otherwise, cardiac output is a measure of systolic BP and peripheral arterial resistance is a measure of diastolic BP. Please don't forget, cardiac output is a measure of systolic BP, peripheral arterial resistance is a measure of systolic BP, diastolic BP. And in the periphery, what happens? In the periphery, the oxygen is getting consumed. Please don't forget, peripheries consume the oxygen. So the peripheries, oxygen consumption happens. So oxygen consumption happens in periphery. So after the oxygen is consumed, the blood, venous blood brings back the blood to the veins, bring back the blood to the heart. So this is called as venous resistance. They also have a resistance known as venous resistance. So if I am going to give 100% oxygen, so if I'm going to give 100% oxygen, the amount of oxygen returned back is calculated by a formula known as mixed venous oxygen saturation. Mixed venous oxygen saturation, called as MVOS. So the normal value of MVOS is 50 to 70%. If it is less than 50%, it is, what does it mean? If less than 50% means more oxygen consumed in the periphery. More than 70% means oxygen is not consumed in the periphery. So please understand this concept. Heart is beating, the blood is going to the peripheries through the arteries, and oxygen is consumed in the peripheries, and the veins are bringing back the blood to the heart. And we will measure the MVOS, which is of the returning blood. So now I will tell you the two common types of shock. Please understand the first important shock I want you to remember Hope is it visible now?
Now it is okay, sir. Video is clear. Audio is clear.
Okay. Net got disconnected. Okay. So we are discussing the two types of shocks dealt: hemorrhagic shock and septic shock. So any issues, please put the message in the group. Okay. So because I'm seeing the WhatsApp your group only. So post any doubts in that, you can please post in the group. So Rahul, record put the two types of shocks, hemorrhagic shock and septic shock. Hemorrhagic shock and septic shock, the important features, don't forget. And coming to the classification of these shocks, I'm just going to give you some important points between all the shocks. Pulse rate, systolic BP, cardiac output, peripheral vascular resistance. This table is taken from Bailey. And this question is being repeatedly asked in the exam. So I want you to remember this table. It is the same content what we discussed. So what about the pulse rate? Please remember, pulse rate is increased in all the shocks except one shock, pulse rate is decreased. This is a repeat MCQ. Which shock pulse rate is decreased means neurogenic shock. So since neurogenic shock, the patient goes for bradycardia. Because of the severe vasovagal shock, the patient will go for bradycardia. So this is very important. All the shock, pulse rate increases, except neurogenic shock, pulse rate decreases. In all the shocks, BP decreases, systolic BP. In septic shock, it may increase or it may decrease. Okay. In all the shocks, cardiac output decreased. In septic shock, it is increased. Very interesting. In septic shock, cardiac output is increased and BP may be increased. Okay. So very important point. Please don't forget this table. Peripheral vascular resistance is increased in hypovolemic shock. It is decreased in all the types of distributive shock. You can see in all the types of distributive shock, it is decreased. So cardiogenic shock behaves more or less like a hemorrhagic shock. So cardiogenic shock behaves more or less like a hemorrhagic shock. A distributive shock is neurogenic, anaphylactic, septic. In all the cases, there is peripheral vasodilatation. Because vasodilatation happens, the blood is redistributed. Please understand it. So vasodilatation causes blood redistribution. So now tell me, where all cases MVOA is less than 50%? In hypovolemic shock and cardiogenic shock. In hypovolemic and cardiogenic shock, MVOS is less than 50%. And in distributive shock, all types of distributive shock, it is more than 70%. So please don't forget this basic point. Say MVOS is less than 50 in hypovolemic and cardiogenic shock, more than 70% in septic shock. So this column is a very important column for PG entrance exams. How to monitor the response. I'm going to tell you how we treat each shock one by one. And when I'm treating a shock, what is the monitors I should never forget for exam? So best clinical parameter to monitor the shock. Can you tell me what is the answer for best clinical parameter? Best clinical parameter is urine output. Best clinical method to look for adequacy of resuscitation is, that is also urine output. So urine output is very important in all shock patients. We should put a Foley's catheter and we should monitor the urine output. So please post any queries in our group, Love and Bailey group. You can post that. So urine output is the best clinical parameter. Best clinical method to look for adequacy of resuscitation is urine output. So best method to look for tissue perfusion. So to look for tissue adequacy of tissue perfusion is also output. See, 3 questions, same answer. Don't get confused. So urine output is the best clinical parameter. It is the best method to look for adequacy of resuscitation and the best to look for tissue perfusion. And how will you calculate the amount of fluid should be given for shock patients, it is by means of central venous pressure. CVP helps you to know how much of fluid should be given. We should not overload. At the time, we should not underload the patient. So it is best to look for CVP. Best lab value to monitor tissue perfusion. What is the best lab monitor? It is serum lactate. All these are asked as repeat MCQs. Serum lactate is the best lab value. See, clinical and overall value, best answer is urine output. They ask you lab value is measuring of serum lactate. In two situations, CVP is not accurate. So therefore, I have to go for pulmonary capillary wedge pressure. Because in those two situations, in the above shocks, the CVP is not accurate. What are the two cases? In which of these cases, CVP is not accurate? Very important, cardiogenic shock. In cardiogenic shock, CVP will not be so much accurate because the cardiac has failed. So we have to depend on pulmonary capillary wedge pressure. And number two, it is septic shock. In septic shock, there is a hyperdynamic circulation, so it will not be accurate. So therefore, in cardiogenic shock and septic shock, for giving fluids, I should do pulmonary capillary wedge pressure. Please remember, I depend on pulmonary capillary wedge pressure in those two cases. In cardiogenic shock and septic shock, I have to depend on pulmonary capillary wedge pressure. So don't forget this table. How to monitor the response of shock to various treatments is very important for your exams. So don't forget this. In green screen freeze. There is a small internet problem in my place today. See, please verify your net also because it's fine for me. Rahul, please watch the show. It's just 1 hour class. Any issues, please tell me. Best clinical parameter is urine output. Best clinical method, look for adequacy of resuscitation as urine output. Best method to calculate amount of fluid is CVP. Best method to monitor lab value is serum lactate. Now, these are the values from Bailey and Lowe. Normal value of urine output is 0.5 ml per kilogram body weight per hour. Okay, it is 0.5 ml per kilogram body weight per hour. Serum lactate less than 2 millimoles per liter. It is called as good resuscitation. You have done a good resuscitation. If it is more than 5 millimoles per liter, it is a bad resuscitation. So please understand, if you are doing good resuscitation, the value should be less than 2 millimoles. If it is more than 5 millimoles, it is bad resuscitation. Normal value of CVP and PCWP, you know that well. So 0 to 8 for CVP. A pulmonary capillary wedge pressure is 10 millimeters mercury. Okay. So now let us discuss each shock one by one in detail. First, let us discuss about hemorrhagic shock. So hemorrhagic shock is of 4 types. Very interesting shock because this is a very important shock dealt by surgeons. So you should know everything about hemorrhagic shock because hemorrhagic shock can be separately asked as a essay question also. So therefore, you have to understand hemorrhagic shock. Among the very important shocks dealt by surgeons is hemorrhagic shock. So hemorrhagic shock we can divide into 4 types. Class 1 is a condition in which 0 to 15% blood is lost. Nothing but less than 750 ml blood is lost. 15 to 30% is nothing but 750 to 1500 ml. 30 to 40% is 1500 to 2000 ml. And more than 40% is more than 2000 ml. So these are the amount of blood lost. According to this category, less than 750, 750 to 1500, 1500 to 2000, more than 2000 ml. So this is very important classification repeatedly asked in exam. Very, very important classification of hemorrhagic shock. So now coming to the clinical features in each shock. So the most important point is in class 1 shock, you will see nothing is happening. Everything is normal. Everything is normal means pulse rate normal, systolic BP normal, diastolic BP normal, pulse pressure is systolic BP minus diastolic BP is normal, respiratory rate is normal, urine output is normal, 30 ml per hour is normal. Okay, base deficit is 0 to minus 2 milliequivalents. Base deficit means what? Patients developing acidosis. As acid is increasing, base gets deficit, no? So that is 0 to minus 2. So everything is normal. CNS is normal. See, this is equal to what? Losing 750 ml of blood is equal to blood donation. What will you do for those patients? Equal to blood donation. What is the treatment of a patient who donates a blood? Nothing to worry, just oral fluids are enough. For these patients, oral fluids are enough for class 1 shock. So class 1 shock is a shock which is nothing to worry at all. So 0 to 15% of the blood, just oral fluids are enough for them. Nothing happens in those cases. So when you come to class 2 shock, here the problem starts. What is the first sign of hemorrhagic shock means? Increasing pulse rate. Increasing pulse rate is the first sign of shock, which is more than 100 per minute. Okay, what other findings are seen? Very important point. Systolic BP is normal. The patients go for peripheral vasoconstriction and the systolic BP will be maintained. So systolic BP is normal and the diastolic BP because of peripheral vasoconstriction is increased. Very interesting point. Diastolic BP is increased because of, I told you, diastolic BP is measured by peripheral arterial resistance. So there is vasoconstriction. So the diastolic BP is increasing in class 2 shock. It is nothing but compensation, compensatory shock. Pulse pressure, therefore, systolic BP minus diastolic BP is decreased. Respiratory rate increases. Urine output starts decreasing. Base deficit -2 to -6. So you need not write accurately the values, but you can write increase, decrease, that and all you can write. Okay, in your essay question, you will not write, so pulse rate 100 to 120 and you respirate rate to 20 to 30, urine output 20 to 30. That is not mandatory because it is only essential for PG entrance for MCQs. But for essay question, you can write this table very clearly. So when will the systolic BP decrease? Systolic BP decreases from class 3 shock. Please don't forget, systolic BP decreases from class 3 shock. So when will the systolic BP decrease? It is from the class 3 shock. Pulse rate still increases. Diastolic BP now decreases because it cannot compensate for more than 30% blood loss. So pulse pressure decreases, respiratory rate increases, urine output goes less, base deficit increases, and systolic BP is not measurable in class 4 shock. Very, very feeble BP. It is not even measurable. BP is more than 140. Patient is confused or comatose. Then diastolic BP is decreased, not recordable. Pulse pressure decreased, respiratory rate increased, everything is increased. So the MCQ, for exam point of view, the MCQ is in which shock pulse rate increases, respiratory rate increases in class 2 shock. In which shock diastolic BP increases is also class 2 shock. It is a compensatory phenomenon. Diastolic BP increases in class 2 shock. Systolic BP decreases from which shock means class 3 shock. Okay, so urine output up to 30 ml you can manage, but less than 30 ml is decreasing urine output. So please remember 20 to 30 ml, 5 to 15 ml, like this is the classification of hemorrhagic shock. So what is the classification of hemorrhagic shock? Now starts the very important concept. So for a patient who is having class 1 shock, what is the management? Class 1 shock, I told you, oral fluids or IV fluids can be given. Class 2 shock, you have to give IV crystalloids. Class 2 is 750 to 1500 ml. Class 3 and 4 will be essentially needing blood transfusion. Blood transfusion you have to give for 3 and 4 shocks. Class 1 oral and IV fluids, IV crystalloids for class 2. Class 3, 4, we have to give blood transfusion. So what is compensated shock? So compensated shock is a shock in which there is adequate blood flow to kidneys, lungs, brain. These 3 essential organs receive the adequate blood flow, and the only signs of compensated shock may be, that is nothing but what? Compensated shock is having only few signs, that is nothing but tachycardia and cool peripheries. Cool peripheries. Tachycardia and cool peripheries. So this is nothing but the patient is now in, example, class 2 shock. Class 2 shock is a compensated shock. Your patient is getting compensated. So class 2 shock, the only signs will be tachycardia and cool peripheries. So class 2 shock is what? Blood loss is 15 to 30%. Okay, 15 to 30% is class 2 shock, is called as compensated shock. This compensated cardiovascular state is maintained by diverting the perfusion from 3 important organs. So 3 unimportant organs. So three important organs are kidney, lungs, and brains. What are the three unimportant organs? GIT, skin, muscles. So there will be no blood flow to these three organs. The blood flow from these organs will be diverted to kidney, lung, and brain. So, and the patients will be developing systemic metabolic acidosis. So metabolic acidosis will happen. Although this is a clinically occult, we need to treat them as early as possible, because if it persists more than 12 hours, MODS can happen. Even compensated shock, MODS happens if you don't treat in 12 hours. If not treated in 12 hours, they also will go for MODS. Then up to what? Blood loss, nothing to worry. Up to 15% blood loss, nothing to worry, because it is equal to blood transfusion. We can discharge the patient. But 15 to 30%, we have to be worried. We have to treat them with the IV fluid. That is why I told you, class 1 shock, oral and IV fluids are enough. They can go home. They can go home, nothing to worry. And this is another classification in 28th edition Bailey. So 28th edition Bailey has given classification of clinical features of shock. In fact, you can write this table in the beginning itself. I told you, you can write an essay question, you can write the clinical features of shock, pathophysiology of shock, and the classical clinical features of shock, compensated, uncompensated, you can write here. So compensated and uncompensated shock, you should understand very basic point. All the things same. Whatever we discussed already is same. So mild shock is nothing but class 2 shock. Moderate shock is nothing but class 3 shock. Severe shock is nothing but class 4. Whatever I discussed in class 2 will come here. What all I discussed in class 2 shock? I discussed urine output is normal. Okay. Pulse rate is increased. Respiratory rate is increased. Blood pressure, systolic blood pressure is normal. So mild acidosis happens. So this is equal to class 2 shock, already I told you. So class 3 shock is nothing but moderate or uncompensated shock. Moderate or uncompensated shock is class 3. Here, what is happening? Hypotension happens, urine output decreases. This is a neat PG MCQ last year. In which of the following types of shock, urine output starts getting reduced? Mild, moderate, severe, it is moderate, okay? It starts decreasing from moderate type of shock. So in moderate type of shock, urine output decreases, BP starts decreases. It's nothing but, you remember one classification. That is, I'm telling you, you remember this one column. Very, very important column. This question has been asked at least 40, 50 times in the past many years of PG entrance exam. So class 1, class 2, class 3, class 4, please don't forget this. So based on that, there is another classification given in Bailey. I want you to know this. Now I am going to the easiest part of the classification discussion. How are you going to manage hemorrhagic shock? So the moment I receive a hemorrhagic shock patients, I should access by putting 2 Venflans. Minimum 2 green Venflans should be inserted. We have to put minimum 2 green Venflans. Can you tell me what is the size of green Venflan? What is the size of green Venflan? Yes, it is 18 gauge Venflan. So we have to put minimum 2 green Venflans. So there's a separate instrument-based question. Venflans will be repeatedly asked in PG entrance questions. So we have to put minimum 2 green Venflan and infuse 1 liter of normal saline. 1 liter of normal saline is the fluid of choice. But if the choice is having blood, blood is the best substitute. Best substitute for blood loss is what? Blood. So if blood is given, that is the best substitute. If blood is not available, because blood will not be readily available until the blood comes, we can give 1 liter of normal saline via 2 green Venflans. If I could not put Venflan because patient is in heavy shock, the veins are collapsed, I should go for IJV route is preferred. If the 2 green Venflan is not able to be applied to the cubital veins, I will go for IJV route. I should put an internal jugular vein route is preferred in those patients. So IJV route is preferred. So now the very interesting concept from 28th edition, what is crash tooth trial in the management of hemorrhagic shock and trauma? Yes, In a patient who is having systolic BP less than 90, pulse rate more than 110 per minute, I should give what? Injection tranexamic acid. Injection tranexamic acid should be given for those patients who are having it. Is a new trial showing there is a benefit. Systolic BP less than 90, pulse rate more than 110, I can give injection tranexamic acid. So that is very important. And blood transfusion, I told you blood is the best substitute, but cross matching and all will take 1 hour. I cannot wait for that time. Therefore, what should I use? The blood group used is O negative. Is a universal blood donor. So in trauma centers, in military, war and all, they have hundreds of O negative blood in the ambulance. They will immediately transfuse because they have no time for cross matching. So in fact, since O negative is in huge demand, for males, we can use O positive. For males, we can use O positive because they're not going to give a childbirth or going to have an RH incompatibility. So this negative positive is mainly related to RH incompatibility of a pregnant females. So therefore, males, you can even give O positive, nothing wrong. Similarly, post-reproductive females also, you can give O positive. These are new points from 28th edition. Previously, these points are not there. There will be only one choice, that is O negative. So New Bailey says we can give O positive for all these cases. This is very important. Okay, please don't forget this. So what is mean by balanced resuscitation? Very important, another update. Balanced resuscitation is, we should not only transfuse blood. When you transfuse one packed red blood cell, I should transfuse one platelet and also one plasma. So this is 1:1:1 ratio. This is done to avoid coagulopathy of doing only blood transfusion, to avoid coagulopathy. என்ன ஆகும், வெறும் blood மட்டும் transfuse பண்ணா what will happen? Only if I do only blood transfusion, but that is means what? Packed red blood cell alone, if I am transfusing, what will happen? The problem that will happen is the patients can develop coagulopathy because blood does not contain coagulation factors. Coagulation factors are deficient in the blood. So therefore, to avoid coagulopathy, I should use 1:1:1 ratio. Okay, so you will understand that in blood transfusion discussion, don't worry. So massive transfusion means more than or equal to 10 units per day in an adult. More than or equal to 10 units per day in an adult is called as massive transfusion. Permissible hypotension is also a new concept. Don't make the systolic BP normal. Systolic BP should be maintained between 70 to 90. Don't bring it to 120. Why is it so? If it is increased more than 90, there will be rebleeding which will happen. Already thrombosed blood vessels stopped. No, those areas will go for rebleeding. If it is less than 70, what will happen? Brain will go for anoxia, anoxic damage of brain. So therefore, it should be maintained at a permissible hypotension level of 70 to 90. So systolic BP should be maintained at a level of 70 to 90 is a permissible hypotension level. Please don't forget this point. So when the BP is more than 90, rebleeding will happen. Less than 70, anoxia will happen. So maintain it between 70 to 90. So this is how you resuscitate a hemorrhagic shock patient. How will you manage a hemorrhagic shock patient? These points you can write in detail in an essay question. So then coming to septic shock management, how will you manage a septic shock patient? So septic shock case is basically, you should understand what is the cause of sepsis. So septic shock management starts with the first line, treat the cause. What is the cause? Can you tell me some example? If it is a perforation, seal the perforation. So please treat the cause. So treat the cause is the most important sepsis. If there is an abscess, drain the abscess. If the patient is in typhoid, treat the typhoid. The patient is having a perforation, treat the perforation. So whatever it is, septic shock, treat the cause. Because as you are not going to treat the septic cause, the septic shock cause, it is going to still produce bacteria more and more. So what is septic shock? Septic shock is defined as sepsis bacteria, which has gone to an organ dysfunction and hypotension. So septic shock can have hypertension also. Sepsis is SIRS plus known foci of infection. So you should understand what is SIRS, something which you read in your physiology. So SIRS is defined by 2 or more of the following. So LTHR. So I used to remember love total hip replacement. LTHR means love total hip replacement. So WBC count, leukocyte count less than 4,000 or more than 12,000. Temperature, okay, less than 35 degrees or more than 38 degrees. So the temperature decreased or increased, WBC count decreased or increased, heart rate more than 90, respiratory rate more than 22, all this will come under SIRS. Any two of this is present means we call the patient is in SIRS. So if 2 or more organs fail, it is called as MODS. All these are complications of septic shock, because very dangerous. If you're not going to treat the patient will die of MODS. To make a simplified scoring for septic shock, they made a quick SOFA score. SOFA score, quick sequential organ failure assessment score with only 3 values, RCB. So remember, Royal Challengers Bangalore will be in SOFA. Remember like that, okay? So respiratory rate more than 20 per minute. Okay, confused, GCS, Glasgow Coma Scale less than 14. When the systolic BP less than 100. So these are the points for RCB. So Royal Challengers Bangalore. So it's a very simple score. When the score is more than 2, it indicates organ dysfunction and the patient has 10% mortality. So quick sequential organ failure assessment score is a very important score. So respiratory rate more than 20, GCS less than 14, systolic BP less than 100. So these 2 values you should remember. And these 2 values are every year asked in NEET PG exam. SIRS and quick sequential organ failure assessment score. And that is a new update in 28th edition Bailey. For the management of sepsis, they simplified the management. The management is give 3 to the patient, take 3 from the patient. That is the management. What is it? Very simple. It is called as surviving sepsis 6. Surviving sepsis 6. So 6 is known as sepsis 6 bundle. It is a resuscitation bundle, very easy, must be completed in 6 hours. Whatever given here should be completed in 6 hours in a patient who is having sepsis or lactate more than 4 millimoles per liter. So what are the 3 given to the patient? I will give IV fluids, antibiotics, and put a catheter, oxygen. So IV fluid, oxygen, antibiotics. So fluid, antibiotics, oxygen are given because it's a septic shock. So I should give antibiotics. Take 3. I will take blood culture. I will take WBC count, complete blood count. I will take lactate level. Lactate level less than 2 millimoles is good resuscitation. More than 5 millimoles is bad resuscitation. So please don't forget, 3 given to the patients, 3 taken away from the patient is sepsis, surviving sepsis. So please don't forget what are the 3 given to the patient. So FAO given to the patient, fluid, antibiotics, oxygen. So FAO given to the patient. So what is given to the patient? FAO. So this is, don't forget this. And what is taken from the patient? You should take blood count, blood culture, and serum lactate. So what are the 3 things? Culture, count, and lactate. So culture, count, and lactate are taken from the patient. So this table, if you write, definitely you're going to get highest score in this essay question. So sepsis guideline is a new update in 28th edition Bailey. Give 3, take 3. That is a concept of surviving sepsis guideline. So this is about the shock. That's actually, this completes the shock. But sometimes when you are writing about hemorrhagic shock, you can write about blood transfusion and blood products also. Is there a role of blood in septic shock? Can you tell me, is there a role? Please remember, blood transfusion has no role in septic shock. No role in septic shock. It is only having helpful in hemorrhagic shock. We are going to discuss blood transfusion because I told you in hemorrhagic shock, I will be giving blood. So can you tell me what is the vasopressor of choice in septic shock? So in shock, we will be giving adrenaline, noradrenaline, dopamine, dopamine. What is the vasopressor of choice in septic shock? So because each shock has some vasopressor, so which is actually discussed in medicine, in pharmacology. So vasopressor of choice in cardiac shock, renal failure, like that you have different vasopressors. No, in septic shock, it is a repeat PG entrance question, noradrenaline. Noradrenaline can be given in septic shock. That is the best vasopressor in septic shock. Okay, and there is no role of blood in septic shock. Blood transfusion is totally related to hemorrhagic shock. So this is a very basic chapter, though it is not a surgical chapter. Since there is a content in Bailey, I'm just giving an outline. How much ml of blood taken from the donor? It is 450 ml. How many times you can donate per year? Maximum 3 times only you can donate per year. So when you are giving blood, what are the infections that will be screened in your blood? HIV 1, 2, hepatitis B virus, hepatitis C virus, and number 4, syphilis. So these are the 4 infections which will be screened in your blood. In India, sometimes they will screen for malaria. In UK, they sometimes screen for Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease. These are 2 important rare diseases. So in UK, they may screen for CJD. In India, they may see for malaria. But commonly done in all the countries is HIV 1, 2, B virus, C virus, syphilis. So packed red blood cells, each unit. What is packed red blood cell? From the whole blood I have taken, which is 450 ml, no? From that, I will allow the RBCs to deposit like this. And I will use only that for some cases, like in anemia, you would have seen in pregnancy, we give only packed red blood cell, which is only 330 ml, which increases the hematocrit 50 to 70% increase. And what is the storage solution in this? Yes, because we cannot store the blood as such. No, we need a storage solution. What is the storage solution now used? Now, latest used solution is saline, adenine, glucose, mannitol. Old solution is no more used. Citrate, phosphate, dextrose is no more used. You can leave it. So saline, adenine, glucose, mannitol is used. I can store the blood for 45 days at a temperature of 2 to 6 degree temperature. I can storage in the fridge. So saline, adenine, glucose, mannitol, 45 days I can store the packed red blood cell in the fridge at 2 to 6 degrees centigrade. What is deficient in this packed red blood cell? Packed red blood cell will not have coagulation factors. So therefore, we prepare fresh frozen plasma rich in 2, 7, 9, 10, which is rich in 2, 7, 9, 10. I will prepare it during the retrieval from the whole blood, and I can store it at minus 40 degrees centigrade for 2 years. So what is the use of fresh frozen plasma? It is very helpful in bleeding cases. In bleeding disorders, I can use fresh frozen plasma, especially in obstructive jaundice patients. When there is a bleeding, this factor will be deficient. So I will use in those patients also fresh frozen plasma. Cryoprecipitate is one rich in factor 8. So that is also stored at minus 40 degrees centigrade for 2 years. And it is used in hemophilia. Hemophiliac patients, we use cryoprecipitate. So fresh frozen plasma 2, 7, 9, 10. Mainly when fresh frozen plasma used is whenever there is increased prothrombin time or INR. When a patient is having increased prothrombin time or INR, we use fresh frozen plasma. Cryoprecipitate is used when in a patient of hemophiliacs. So there is another component which is prepared from the blood, that is platelets. The major problem in platelets is it can be stored only for 5 days. Therefore, if you are going to prepare platelets, I can use the platelets only for 5 days. It is stored at 20 to 24 degrees centigrade room temperature. That is a normal room temperature. So 24 degrees centigrade is a room temperature. So it's stored at room temperature for 5 days. It is used in cases of dengue. You know very well, it is used in times of dengue and other thrombocytopenias. So any patients who are having thrombocytopenia, you will use it. Dengue, you will use it. So platelet is very commonly used in patients who are on clopidogrel therapy and about to undergo any major surgery. So it is used on patients on clopidogrel undergoing major surgery, and during the surgery there is an active bleeding. We have to transfuse platelets. That is why we used to discuss in your anesthesia topic clopidogrel should be stopped the 5 days before surgery. But what can I do in an emergency surgery? In emergency surgery, I had to do the surgery. No, such times I will start platelets. Prothrombin complex concentrates. It is another one new substance which is in the powder form. Instead of depending on the blood bank, I can store this ampule. Please remember, it is an ampule containing powder in the ward itself. I can have it and I can mix it and I can use it immediately. It is rich in factors 2, 9, 10, factor 7 also can be included. It is more or less like what? Prothrombin complex concentrates is nothing but which can increase the prothrombin time. That means what? It is like FFP. It is like FFP. Like fresh frozen plasma, I can use it. It is used in emergency reversal in a warfarin toxicity. Warfarin toxicity induced severe hemorrhage. I can use this prothrombin complex concentrates. You can understand this contents only when you understand the extrinsic pathway and intrinsic pathway in physiology. So when you understand extrinsic and intrinsic pathway, what are the drugs acting on the extrinsic pathway? What is the method to monitor the extrinsic pathway problems? That and all you should understand before going to read blood transfusion. So see, when next exam is going to come in future, it is going to just ask applied questions from basic science. Just applied questions from here. They will be correlating with the basic science. That's all. Okay. So warfarin anticoagulant can be reversed with prothrombin complex concentrates. So when a patient, when you are going to blood bank, how long the blood bank medical officer will take for cross matching? So cross matching is done in 45 minutes in blood bank, and blood received must be transfused in 1 to 4 hours. Uncrossed matched blood used in trauma is, what is uncrossed matched blood? I will not wait for cross matching. I will immediately use it. That is O negative. What is mean by autologous blood transfusion? 3 weeks before I am going to undergo one surgery. For example, I am going to undergo knee replacement operation. So what will I do? I will donate one of my unit and I will store it in the blood bank and I will use my own blood after 3 weeks. So 3 weeks before I will donate and I will use it for myself. This is known as autologous blood transfusion. So it is usually 3 weeks. In old textbooks, it is 3 weeks because old component used in those days is citrate phosphate dextrose. So citrate phosphate dextrose is a storage component which is actually stored the blood only for 3 weeks. So therefore, they are still mentioning 3 weeks. Actually, from the new book, you can see saline adenine glucose mannitol is used for 45 days. So to be frank, autologous blood transfusion, we can donate 45 days before also. But as of now, the MCQ from old Bailey is 3 weeks. Okay. What is massive blood transfusion? More than 10 units per day. More than or equal to 10 units per day is called as massive blood transfusion. So now what is the complication of doing it? This is the surgeon's important topic. So for whatever I discussed is pathology question. So for me as a surgeon, this is very important. I am going to transfuse 1 unit of blood. For example, you are the house surgeon, you are bringing the blood and transfusing the blood to the patient. You are transfusing a wrong blood. For example, B group blood is transfused in an A group patient. What is the first sign the patient will tell? Awake patient will tell. Sir, I'm having itching. That is the first sign. Itching is the first sign. Immediately you should stop the blood. So patient tells, I'm having severe itching on the flow of the way. So immediately stop the blood. First sign in anesthetized patient. The patient is in anesthesia. The patient cannot tell itching, he's in general anesthesia. So what will be the first sign? The first sign is sudden hypotension. There will be sudden fall in BP. The moment you start the blood, suddenly there is a fall in BP. Okay, that is one sign noted by the anesthetist. And as surgeons, we will note unusual bleeding from operative sites. Unusual bleeding from operative sites. Already stopped bleeding area, now suddenly bleeding. Unusual bleeding from operative site is the first sign in anesthetized patient. So late sign in wrong cross-matched transfusion is what? So late sign in wrong cross-matched sign transfusion is, that is very important. Patient develops hematuria and acute kidney injury. So if you don't recognize it, the patients will develop hematuria and they will go for renal failure. Please don't forget this. What is the cause of? Most common complication is this. Most commonly, when you go for blood transfusion, when you transfuse the blood, immediately the patient will develop this complication. What is the cause of febrile non-hemolytic? Please remember, there is no hemolysis, but patient develops fever and chills. What is the cause? It is due to WBC in the blood. It is known as what the cause of acute febrile non-hemolytic transfusion reaction is because of if I am giving my blood to you, my body is having some WBC, that will cause some reaction in your body. That is known as non-hemolytic febrile reaction is due to WBC in the blood causes this problem. Please don't forget it is because of the WBC in the blood causes this issue. Please don't forget this. Number one. And how to treat this? Treatment of choice for these patients, what we usually do, we will put Avil and Decadron. This is what we do in our hospitals. So for these type of cases, nothing to worry, just put Avil, Decadron, we can continue the transfusion. To avoid this type of complication, they are using now one filter shown here. This is a very interesting filter, which definitely you would have not seen in our hospitals. In our medical college hospitals, we would have not seen this. கண்டிப்பா இது நம்ம ஹாஸ்பிட்டல் கிடையாது. வெஸ்டர்ன் கண்ட்ரீஸ்ல எய்ம்ஸ் இன்ஸ்டிடியூட்ஸ்ல இந்த ஃபில்டர் இருக்கும். இது வேற ஒண்ணும் இல்லை, இது ஒரு பிளட் செட் தான். பிளட் செட் நம்ம பார்த்ததுல இந்த மாதிரி இருக்காது, வெறும் ஒரு ஃபில்டர் மாதிரி, சாதா ஃபில்டர் மாதிரி இருக்கும், கிளாட்டை மட்டும் ஃபில்டர் பண்ணும். பட் திஸ் இஸ் பிளட் செட் கண்டெய்னிங் known as leukocyte reduction filter. இது வழியா பிளட் போகும்போது WBC ஃபில்டர் பண்ணிடும். This is an image-based question asked in AIIMS. Leukocyte reduction filter is shown here. So as you are transfusing blood, the WBC will be filtered in this device, and that will be very important. So please don't forget leukocyte reduction filter. The added advantage of this filter is it can also filter Creutzfeldt-Jakob disease. It can also filter Creutzfeldt-Jakob disease. Please don't forget this. So it can filter WBC and Creutzfeldt-Jakob disease. அதனால Western countries la compulsory use பண்ணுவாங்க. So what are the infections which can happen? The infections which can happen are B and C. One more virus they have found out, that is G virus, HIV-1, 2, malaria, bacteria. So all these are list of infections which can happen on blood transfusion as a complication of single unit transfusion. Now, complication of more than 10 units per day, massive transfusion. What all problems can happen? Patients can develop coagulopathy. I told you the patients have citrate phosphate dextrose. The citrate will bind with the calcium in the blood and cause hypocalcemia. They can go for RBC lysis and can cause hyperkalemia. Rarely hypoxia, very important. Both hyper, both are seen, but commonly seen as hyperkalemia. Hypothermia, metabolic alkalosis. Why there is metabolic alkalosis? The citrate phosphate dextrose, that storage component, that citrate is metabolized in the liver to bicarbonate. So citrate, sodium citrate becomes sodium bicarbonate in the liver. Therefore, metabolic alkalosis. But they can also develop metabolic acidosis. This is 100 times asked MCQ. Please don't forget. And iron overload. So what are all the electrolyte imbalances seen on massive blood transfusion? Means potassium decreased as well as increased, calcium decreased, metabolic alkalosis or acidosis. So both can happen. So all these are various complications. So usually in MCQ, they will give you hypercalcemia. That is not seen as hypercalcemia, not seen. Hypocalcemia, hypokalemia, hyperkalemia, metabolic acidosis, metabolic alkalosis is seen. So therefore, as a surgeon, when will you do blood transfusion based on hemoglobin? When it is more than 8 grams, no need of transfusion. Please remember this point. No need of transfusion even for any surgery, even during surgery. Even if I'm going to take gastrectomy, if the hemoglobin is more than 8 grams, I will never do transfusion. See, very interesting, which is though not practiced in our hospitals. Just remember, more than 8 grams, no need of transfusion even for surgery. 6 to 8 grams transfusion unlikely to be beneficial in the absence of bleeding or any surgery. So therefore means what? 6 to 8 grams, if you are going to do surgery, do transfusion. Otherwise, no need. Less than 6 grams, indication of transfusion is dash. So when will you do blood transfusion means from less than 6 grams. This is a very interesting table for PG entrance exams. Less than 6 grams is an indication of transfusion. 6 to 8 gram, we will do transfusion only if I am planning for a surgery. More than 8 grams, no need of transfusion even for surgery. So this is a very simple essay question. Don't get confused and don't get complicated. Just remember the concepts. What all things should I write in a shock? So the explain shock will be asked as an essay question. Just write about pathophysiology of shock. I told you what happens in various types of shock. Pathophysiology behind shock. You can write the image I told you that you can write first. And types of shocks. Second heading is types of shock. You can write. There are 3 types of shock: hypolimic shock, distributive shock, cardiogenic shock. So distributive shock further divided into septic shock, anaphylactic shock, neurogenic shock. You can write about it and you can put the table I told you, you can put the table of differentiation of the shocks. In that table also it showed you bradycardia is seen only in neurogenic shock. All other shocks have tachycardia. All the shocks have hypotension. Septic shock may have hypertension. That table you have to write types of shock and classification of severity of shock. Classification of severity of shock. I told you there are 3 categories: mild, moderate, severe. Mild, moderate, severe are the 3 types. Mild is nothing but the same class 2 shock which we discussed in hemorrhagic. Moderate is class 3. Severe is class 4. This is one type of classification. What is other classification? Another classification is compensated shock and decompensated shock. This is another classification. So compensated shock is nothing but class 2 shock. Decompensated is class 3 and 4 shock. So this is the next heading you should mind. So pathophysiology, types of shock with the table containing BP, pulse rate, everything. Classification of severity, mild, moderate, severe. And you can write about compensated, decompensated shock. And you can write about monitoring of the shock. I told you how will you monitoring of the shock. Urine output, CVP, PCWP, all those things you can write about monitoring of the shock. Then you have to go for explanation of each shock in detail. So hemorrhagic shock in detail. So they won't expect you to write about all the shocks. You can write only about hemorrhagic shock. So hemorrhagic shock classification. So class 1, class 2, class 3, class 4, you write the table. Number 2, management. I told you how will you manage the hemorrhagic shock, about the crash to trial, IV fluids, blood. In that you can write detailed explanation of blood can be done. The explanation of blood products can be done in this heading. If you have time, you can write it. So detailed explanation of blood products, what group we will do, what complication will happen in hemorrhagic shock, all those things you can write in hemorrhagic shock. But management of hemorrhagic shock is a very favorite initial question. Then you have to write about septic shock. So don't forget to write about the class scorings like SIRS. What is SIRS? So love, total hip replacement, leukocyte count, heart rate, then temperature and respiratory rate. Then you write about Q-SOFA score. And don't forget to write about sepsis 6. Sepsis 6 guidelines. So give 3, take 3. Don't forget give 3, take 3 should be written. And after writing the septic shock, then that's more than enough if you are going to write about it. And if you have time, you can write few points about blood transfusion complications. So blood transfusion complications can be written in this. So I don't think you will maybe expected to write about cardiogenic shock and other types of neurogenic shock and all, but you can write one line, just one line. Mostly you will be reading all of them in medicine. So one line about each shock. For example, cardiogenic shock. So cardiogenic shock, how will you manage? Medicine related question. If it is a myocardial infarction, you have to manage it accordingly. So neurogenic shock, anaphylactic shock, few lines which you will be reading in medicine, you can apply here. So anaphylactic shock. So though, because in surgery, we don't manage any of these cases, so we might not have good idea about discussing these type of shocks. So because these shocks will be again discussed in medicine. So if you have little knowledge, don't write enormous points because you have no time to write for so many hours in these questions. So konjam points, cardiogenic pati konjam, neurogenic pati konjam, anaphylactic pati konjam, just few points you can write. Causes management like that, you can finish off these type of shocks. So this is about the shock. So it's an essay question, very commonly asked essay question. I want you to remember about this question. The MBOS, you didn't see, you could not understand. Septic shock is enough to read in Bailey. Don't read any other book. Don't read any other book. MBOS alone, I will tell you now. Since some of you told that, have mentioned that MBOS, it got disconnected. MBOS is a repeat short MCQ topic in exams. So MBOS is nothing but, please understand this diagram. This diagram I have told, same diagram. So I am going to give oxygen that is going to the peripheries. Peripheries are consuming the oxygen coming back. So as it is coming back, see MVOS, mixed venous oxygen saturation, normal value is 50 to 70%. If I give 100% oxygen, the amount of oxygen returning back is 50 to 70%. This is normal value. So I give 100%, the amount returning back is 50 to 70. If it is more than 70, it is septic shock. Means what? No oxygen is taken by the peripheries in septic shock. It is less than 50% means it is hemorrhagic shock. More oxygen is taken by the periphery. Okay, septic shock is more than 70%. Hemorrhagic shock is less than 50%. More oxygen is taken. So in otherwise, what are other places like MVO is less than 50% means hemorrhagic shock and cardiogenic shock. Septic shock and other distributive shocks also you have more than 70%. So whatever it is, we can manage the patients and we have to monitor urine output. So urine output is a very important monitoring of shock. So we have to monitor. It is a best clinical parameter. It is a best parameter to look for resuscitation. Okay, best parameter for resuscitation. It is a best parameter for adequacy of resuscitation. It is a best parameter for tissue perfusion. So everything is question. Answer is urine output. So only one answer is CVP. That is CVP is best for fluid calculation. For fluid calculation, the best is CVP. That is the only point for CVP. CVP is not accurate in cardiogenic shock and in septic shock. Therefore, in those two cases, I'll go for PCWP. Okay, these are the points we have discussed in monitoring of the shock. So you can write it. This is enough. Whatever I've told you is enough for writing an essay question. So don't need to write everything even in the book. But please understand, a compensatory shock up to 15%, you can manage only up to 15%. You can manage with for up to 12 hours. Up to 15%, no need to worry. 15 to 30% we can manage only up to 12 hours. Within 12 hours, we have to manage them. Otherwise, they'll go for MODS. Okay. So I think this video is recorded also. So you'll be getting it. So don't worry. So see you all in another session soon.